Good morning, everyone. The Unit-Based Safety Council has decided to look at our use of physical and chemical restraints in the agitated patient. According to Richmond in 2012, this Joint Commission and Centers for Medicare and Medicaid look at low restraint use as a quality indicator. Our patients are often anxious and frightened when a surgical intervention is needed. The presence of underlying mental illness and unknown effects of anesthetic can exacerbate their anxiety and result in violence. Our goal in introducing verbal de-escalation strategies is to maintain the safety of our patients, visitors, and staff. What is verbal de-escalation? Richmond in 2012 defines verbal de-escalation as the act of verbally engaging the patient to allow them to regain control of their emotions. Think of this as calming the patient down or helping the patient calm themselves. Richmond in 2012 suggests that learning to develop a verbal loop with the patient allows us to listen to the patient, find out why they are upset, agree or validate their position, and then tell the patient what we need them to do to remain safe. It is not uncommon to have to repeat what you would like for the patient to do several times before they may actually hear you. Richmond in 2012 also points out, once mastered, verbal de-escalation can be successful in less than 5 minutes. A few of the techniques that we will work on are space. Give the agitated patient space. One example is 2 arm lengths distance between you and the patient. Tone. Use a calm tone when speaking to the patient. De-escalation. Learn to develop the verbal loop. And finally, documentation. Accurately document when you have had to use any of the de-escalation techniques. You may wonder why we need to learn verbal de-escalation strategies. Well, Tischler in 2013 suggests that there is a link between having adequately trained staff and a lower incidence of violence in patients. This could simply be because staff are familiar with the risk associated with violence, recognize symptoms, and know how to avoid potential triggers. Richmond in 2012 suggests that using force to subdue a patient only reinforces their perception that force is necessary. In their article, Violence and Mental Illness, Reeve and Oeltjen in 2008 point out that as healthcare providers, we must be aware that a patient's violence may be motivated by their hallucination or delusions. The patient may be afraid that you are trying to harm them. And finally, in 2010, the Joint Commission supported healthcare workers learning verbal de-escalation tools. We will begin by scheduling existing staff to attend training sessions over the next 2 weeks. Upon completion of training, we will begin practicing verbal de-escalation techniques immediately. We will also require all new hired employees to go through training. Training sessions will include an introduction into the techniques, and we will role play to become more comfortable when caring for agitated patients. The Unit Safety Council has proposed a 3-month trial period. Staff are asked to accurately document all incidences involving patients in the electronic medical record. If you use a de-escalation technique, whether or not you were able to calm the patient down, and if physical or chemical restraints were used. Matley in 2016 reminds us that accurate documentation allows for the analysis of data, which can lead to quality improvement. We ask that we will also have staff complete a survey when they have used de-escalation techniques to determine whether or not you feel they were useful. The Unit-Based Council will measure the data to determine if utilizing these techniques reduces our use of chemical and physical restraints and provide a benefit to our patients and our staff, and we will report back to you at our next meeting. Please do not hesitate to ask any questions as we implement these changes. Thank you for your time.